It's my pleasure now to invite Chelsea Davis to the podium. So Chelsea has a background in intensive care nursing and has been working as a clinical research nurse at the Princess Alexandra Hospital Intensive Care Unit for the past 5 years. During this time, she's been involved in project development and design, ethics and governance submissions and management, participant recruitment and consenting, data collection processes, writing and dissemination. And I'm exhausted. Welcome, Chelsea.
Thank you for having me here today. I'm here from the Princess Alexandra Hospital. So it's a 780-bed tertiary referral hospital in Brisbane. Our ICU's got 26 beds and we admit over 2,000 patients every year. Now, about half of these patients spend about 4 to 5 nights in our ICU. And up until a few years ago, we really didn't have any resources to guide our staff on how to help our patients sleep here. So we know that interrupted sleeps can impair the normal physiological functioning of the body. It can impact negatively on our patient's psychological health, and it's also been linked to that increased risk of developing delirium. Yet we all know that the ICU environment's not necessarily conducive to creating a restful, peaceful sleeping area. It's changeable 24-hour care. There's noise, continuous lighting. Our patients have got invasive interventions and OBS being continued out. And factoring in, our patients have probably got pain, discomfort and anxiety as well. So we've heard that sleep bundles can be introduced to address and manage some of these issues simultaneously that affect on our patients' sleep. So between March 2014 and February 2015, we recruited just over 100 patients and we used the Richards-Campbell Sleep Questionnaire, the RCSQ, to measure their sleep. So this is a 5-item visual analogue scale. It looks at sleep depth, sleep latency, the time spent asleep, how long it took to get back to sleep, and overall sleep quality. So we were able to validate the use of the RCSQ effectively in this for our patients to self-report on their sleep. However, it showed us that our average overall sleep for our patients was only 44 out of 100. We found absolutely no correlation between patients' self-reports of sleep and how their nurses overnight said they slept. Our patients were able to tell us things that actually helped or hindered their sleep. And at this stage, we didn't find any difference in sleep scores for those who were delirious or not, and that was defined as by patients having positive CAM ICU scores. So subsequently, a practice change group came together. We wanted to improve sleep, and we did this by trying to implement a unit-wide sleep bundle. So the next part of this study, our aims were then to see if we could improve the quantity and quality of sleep for our patients, to actually implement and then evaluate the effectiveness of having a sleep bundle, and looking at our current relationships then between patient self-reports of sleep and delirium. The project was run as a mixed methods comparative study. Our participants had to be at least 18 years old. They needed to be able to communicate well enough with us to tell us how they slept. They spent at least 24 hours in the ICU, and we excluded anyone that had any known or suspected pre-existing sleep disorder, dementia or misuse of substances. Aiming for 100 participants each group. Data were analysed using median, interquartile range and Mann-Whitney 2 sample tests for continuous variables and the chi-squared statistics for categorical variables. And significance was considered if P was less than 0.05, and we received ethics approval for this. So you won't be able to read too much of what's on the slide. This was just one of the posters that we brought out to advertise some of the changes. All our interventions were really designed on feedback from our patients in the pre-period, from our staff that gave us feedback, and also what the literature suggested. So we had this big push to have more structured day and night periods with like a formalised rest period, just to discourage snoozing on and off throughout the day and not sleeping at night. We brought in the RCSQ as part of regular practice for our staff to do in the mornings. Had a big push for advanced planning of our patients. So in the morning, can we start then talking about mobilising our patients? Can we then have our discussions with our doctors on the morning ward round about pain relief and sleeping medications, things like that. We had more earplugs and eye masks made accessible. We also then brought out a formalised policy, and we had a large amount of education to roll this all out. So about 9 months after we did bring out the sleep bundle, we then began our post-intervention data collection using the same data collections as before. So what did we find? Well, we had very similar demographic characteristics between the two groups. The only thing that was different was the hospital length of stay, which was significantly shorter for the post period. We did also collect baseline sleep, or on a scale of 0 to 100, how patients rated how they slept at home, but that wasn't significantly different for the two periods. This next one here looks at the RCSQ scores from both periods. So we've got the pre-period in the orange and the blue period, the post-period is the blue. And the higher the number, the higher the sleep score they gave us. So there's just a very general slight improvement in all of the areas, except for that one of time asleep. This was actually a statistically significant improvement in the amount of time that patients reported being asleep in the post-period. However, the overall RCSQ score, which was the average of all 5 of those, wasn't significantly different between the two time points. This next one just looks at some of the feedback that our patients were able to give us. So the first table, the blue one, this looks at items that patients said helped them get to sleep. And you'll see that in the pre-period, we had a lot more reports of like a dark, quiet environment and pharmacological measures as helping them than in the post-period. However, we're assuming that this is though because of with the practice change, we then had lights off same time every night. We then were more mindful of our noise. And we had the advanced planning of pain relief and sleeping medications. So for the post-period then, this was then seen as usual practice rather than just an exception for our patients. And we can see this supported as well by that table in the red, which were the items that patients said made it hard to get to sleep. And you see the post-period, there are far few reports of environmental factors, pain, and medication management being reported in this time. As far as delirium went, we didn't see any significant difference between the two time periods for the sleep scores and delirium, but we did see significantly less days that patients were affected by delirium in the post-period. This table here is just looking exclusively at our post-period or current sleep scores and delirium. Pink is for patients that did have delirium in their ICU admission, and blue is no delirium. And generally you can see that patients who had delirium reported worse sleep scores. And there's 2 little sections I've highlighted there, the latency and return to sleep. These were significantly worse, and their overall RCSQ scores were also significantly worse. So the primary aim that we had for this project was to improve our sleep quality and quantity. Unfortunately, the overall improvement in sleep quality didn't significantly increase. However, in saying this still, on average for this cohort that had already excluded patients that had any pre-existing sleep disorders, their average sleep at home was still only rated about 70 out of 100 anyways. Now for sleep quantity though, we did see that statistically significant improvement in the amount of time that patients reported being asleep in that post-period. So the improvement in the perceived sleep quantity, that could also be reflected in by the feedback we did see from our patients, where they did report on a lot less disturbances like lights and noise. And we did also link this to, we had a very positive uptake of this intervention by our staff, and the overall adherence to it was seen to be really embraced. However, the limitation of actually introducing all of these things is this in a sleep bundle was that we can't look at each individual component to see how effective they were as they were introduced collectively. So while we saw no significant improvement between the sleep scores and delirium between the 2 time periods, we did see that significant improvement in the number of days that patients were affected by delirium in the post-period. In the post-period as well, the patients did report more difficulties in initially falling asleep, falling back to sleep, and their overall sleep score. But we've had to use real caution when comparing delirium here to sleep. We know delirium is very multifactorial, and in this project, we were only able to compare participants that had delirium that didn't impact on their ability to communicate with us, The delirium occurrence may have only been intermittent. And of course, there's the possibility that they didn't tell us the right answers. So if we really wanted to explore that more, we would have to look at polysomnography or something else, but that was above the resources of this project. So in summary, just implementation of a unit-wide sleep bundle was effective for us in improving perceived sleep quantity and reducing the number of delirium days, and it was generally really well embraced by our unit. Obviously, we still have areas for improvement, but we had the interventions that were designed based upon staff and patient feedback, and they were process-friendly and very multi-pronged. Thank you.
Thanks, Chelsea.
Any questions from the floor?
Been a struggle to get all the staff on board. There always seems to be that night shift nurse who wants to stack the fluid or do some kind of cleaning. You didn't have any struggles with getting the whole unit compliant? Because it only takes one.
I know. The interesting thing is when we had part of the education for all of this, we actually made a red session through like the sessions we have for our nurses, and they were the ones who actually gave a big amount of feedback and large discussions with them, and it seemed to really get everybody on board. And then there's been like a few, I guess, almost champions of it, and it's just, it has definitely seemed to be embraced quite well. We hear a lot of reports regularly of people who've really taken it on board.
Chelsea, can I ask a quick question while waiting on anybody else? I was curious because a couple of times you referred to the amount of sleep patients reported that they had. So how did they know how long they'd been asleep?
So the question specifically on the RCSQ score was, so it was a scale of 0 to 100, and it was 0 being you were asleep all night,
right,
to 100 being you were awake all night. Hey, no. 0 being you were awake all night, and 100 being you were asleep all night. And they, on that scale, that's where they wrote down how they felt.
Okay, so it's their perception of how much sleep they had, not actually how much sleep they had. Yeah.
Chelsea, what inspired you to... Sorry, Chelsea, I've just got a question. What inspired you to do this study?
Well, we'd seen a few articles come out about sleep bundles, and we knew that there was nothing in our unit, and you still hear a lot of complaints from patients about their sleep. Just, I guess one thing led to another, and then we got going with that.
Okay, thank you.